We'll go ahead and get started right now. Good morning, everyone. I'm Margaret Lynn, Director of Clinical Research Development at the Tennessee Clinical and Translational Science Institute here at UTHSC. I, along with Rita Brand, the Tennessee CTSI Director of Administration, want to welcome you to Research 103. And the goal of this 6-part series is to provide advanced information for research study conduct. Research 103 follows Research 101 and 102, which were offered in the spring and fall of 2020. And if you weren't able to attend those sessions, those recordings are available on our website. You can go to the search engine at the UTHSC homepage and enter Research 101 or Research 102 to find them. Or you can email me at m, as in Margaret, at Lynn, L-Y-N-N, at uthsc.edu. We're recording this session and all of the Research 103 sessions, and they will be available on our website soon. I want to thank UTHSC Information Technology Department for all of their help. Xavier is in our background helping us, and we really appreciate him. During this session, your microphone has been muted, but you can use the Q&A function at the bottom of your screen to ask questions, and those will be asked at the end of the session. If there's any kind of technical difficulty during the session and we can't resolve it quickly, then we will post the session on our website and you will be notified of the availability. You will receive an evaluation of this session by email, and after you complete that evaluation, you will receive a certificate of attendance, and be looking for that by email within 10 business days. Dorita Brand and I have no real or apparent financial disclosures. And so we'll get to our session today. It's on diversity and inclusion in research. Our speaker is Mona Newsom Wicks, PhD, RN, FAAN. And Mona received her Associate and Bachelor of Science degrees in nursing from the University of Memphis in 1978 and 1981. She earned the MSN, Medical and Surgical Nursing, from the University of Tennessee, Memphis, 1987, and a PhD from Wayne State University in 1992. A professor and department chair for the UTHSC College of Nursing, Dr. Wicks is an experienced researcher, author, and educator. The 84 papers that she has published as an author and co-author address the health of ethnic minority populations, family theory, family caregivers, chronic illnesses, and enhancing educational outcomes of students from disadvantaged backgrounds. Dr. Wicks has published refereed journal articles and abstracts and book chapters and newsletter articles. A former contributing writer for Medscape Transplantation, Mona is an assistant editor for the Journal of Nursing Education. She serves on the editorial board of the American Journal of Health Behavior and manuscript reviewer for several nursing and interdisciplinary journals. She previously served several terms as a member of 2 NIH review panels and received grants from federal and private funding agencies. Inducted as a fellow of the American Academy of Nursing in 2010, Mona serves on its Cultural Competence and Health Equity Expert Panel. Community service activities reflect her commitment to mentoring and supporting disadvantaged children and families. For 6 years, she served as the research mentor for the Memphis Achievers, which provided high school and college students the opportunity to present research and learn about science and health professions careers at the National Annual Biomedical Research Conference for minority students. And in addition to this amazing history of her professional accomplishments, she's just about the nicest person you'll ever meet. So Mona, I'm going to turn it over to you.
Thank you, Margaret. And good morning, and thank you for inviting me to present today's topic, diversity and inclusion in research. I'm extremely pleased to join the group to discuss a topic whose value is well documented as important to providing optimal care to all Americans. A commitment to conducting research that includes diverse populations is a commitment that addresses the needs of all taxpayers who fund scientific discoveries through clinical and biomedical research. As we complete the presentation today, it is our hope that you will be more knowledgeable and comfortable explaining the importance of diversity and inclusion in clinical and biomedical research. Evaluate the effectiveness of the various practices you are implementing currently or have used previously to enhance the inclusion of diverse populations. Finally, I hope that you will go back to your respective projects to look for opportunities to implement some of the commonly recommended approaches which we will discuss today. But more importantly, I hope that you will discuss with your team members why you believe these strategies could bear fruit in your target populations. As we start our discussion, let's begin with two critical definitions. Sharing these definitions as we begin provides the opportunity to communicate using a single frame of reference regarding diversity and inclusion, the central concepts of today's presentation. Diversity is the range of human experiences, including but not limited to race, ethnicity, gender, gender identity, sexual orientation, age, social class, physical ability or attributes, religious or ethical value systems, national origin or political beliefs. As we think about people as members of groups, it is critical to acknowledge that multiple attributes can describe people as individuals and as members of populations or groups. In other words, the intersection of these attributes contributes to the human experience. Diversity is more than a single attribute. Diversity is more than ways of being. It also includes ways of knowing. How we experience the world influences what we know and the decisions we make, including healthcare decisions. This perspective is true for you, for me, and the patients we potentially recruit to the studies that we conduct. Patients experience historical events, and their experiences inform the decisions to participate in research. We as researchers can influence these experiences and change perceptions using specific approaches that demonstrate respect for the people we want to include in our research. It requires leaving stereotypes and biases at the door and meeting patients where they are regarding their understanding of clinical research. Intentional diversity strategies get people to the proverbial table. They get them to the study, acknowledging that they can contribute in meaningful ways to the menu, the data, the results, and the conclusion. Inclusion and diversity are needed so that people have a sense that they have something meaningful to contribute to finding solutions to critical healthcare problems. Inclusion creates a sense of belonging that has the potential to manifest as participating in and advocating for research in the communities where people live, work, and play. Inclusion can change the dynamic and the narrative between the researcher and the participant. Inclusion reflects sitting at the table because you've been invited and you're welcome. Participation means contributing to the menu. If researchers and their teams can create a sense of purpose and meaningfulness, then we can achieve the goal of inclusion in scientific research. What is inclusion? It's the state of being valued, respected, and supported. It's about focusing on the needs of every individual and ensuring the right conditions are in place for each person to achieve his, her, or their full potential. The goal of inclusion is to value each person affected by a disease, a condition, or an issue. Inclusion requires an appreciation for what diverse groups can contribute to solutions when invited to the table. Everyone in the study must perceive that their perspectives are valued and acknowledged as important. In the case of research subjects who report different side effects to a new drug, an inclusive team will hear the side effects and not discount their importance. The goal of science is to answer questions and to look at patterns and relationships. Can we look for answers, relationships, and patterns if we don't examine all the data from all participants with a clear view and appreciation for nuances? Bias is inherent in research because we ask questions and interpret answers based on our philosophical perspectives and lived experiences. But if we strive to be inclusive, we will systematically attend to everything that a study reveals as potentially valuable. So let's take a look at why what are the scientific reasons for addressing diversity and inclusion in clinical and biomedical research? There are many. Research allows us to target specific populations, to collect data from samples, and if we design our studies well, we are confident when generalizing these findings. The challenge we face is that our samples often don't reflect the target populations because of a lack of diversity. So conducting research is a balancing act. It requires balancing resource investment with returns on investment. The goal is to acquire the best information about treatments to influence the most people at the lowest cost. The puzzle is that we exclude the people who are disproportionately affected by the disease and who experience the most devastating and frequent effects. Have we made the best use of these resources when we exclude these populations? We have known for decades that the demographic attributes of our nation is changing. These changes further support the need for diversifying our research samples. As the number of white Americans decreases, as depicted in this slide, the need for diversity in our research subjects becomes increasingly clear and critical. These data show that a 9-point decrease in the white US population over the 9-year period reported from 2000 to, or 19-year period reported from 2000 to 2019 depicted reflects a significant drop, or a 9-point drop, and the 6-point drop is present for your Hispanic and Latinx population. Can we afford to intentionally or unintentionally disregard ethnic and racial diversity in our research samples? We can make the same arguments regarding the inclusion of older adults in research trials, or women for that matter, but specifically for older adults because of the growth of the number of persons who are 65 years of age and older, as this number is unprecedented. Between 2018 and 2060, the rise in older adults will increase from 16% of the population to 23% of the population, which is a quarter of the population. Can we afford to exclude or under-recruit older Americans from drug trials, behavioral trials, educational trials? Of note, non-white Hispanics will account for more than half of all Americans in 2060, despite the increasing diversity in the population of older Americans. These 2018 data from the United States Food and Drug Administration show that clinical trials participation was overwhelmingly members of white populations. While ethnic minorities are participating more in drug trials, the numbers remain abysmal. Clinical science, as a rule, does not reflect the US population. Data depicted in this table tells a concerning story as well regarding gaps in diversity representation in oncology trials. Too often, participants in oncology trials are white males younger than age 65. Recruiting white males younger than age 65 is essential. In a similar fashion, recruiting other groups who reflect our citizenry is also crucial. Ethnic minorities and older adults are disproportionately diagnosed with cancer. We need to find ways to engage these populations that experience striking disparities in cancer incidence and mortality. Diversity matters in behavioral interventions, drug trials, and medical device trials, and they should be studied in populations reflecting the targeted populations who will be using these resources. Some groups respond differently to medicine, such as women and older adults, experiencing different side effect profiles. If they're not in the study, how do we learn that information? It's important that we lead or we create or develop more robust and complete data that increases understanding of differences in treatment responses across diverse groups and avoidance of adverse events to avoid adverse events, because this may be linked to specific populations. We won't find about these adverse events in specific populations if these individuals are underrepresented in our study samples. Clinical and biomedical research that does not capture the most affected, the targeted treatment populations, can impose more significant risks for the omitted populations when these treatments are implemented without scientific data. And we are a data-driven healthcare system. We have mentioned that some groups respond differently to therapies. We need the best research to ensure the best outcomes. Achieving these goals requires the inclusion of the targeted clinical populations. O and colleagues effectively argue that diversity allows us to explore the complexities of ancestral influences, environmental exposures, and the social factors experienced by diverse U.S. populations. In one study, 75% of Pacific Islanders were unable to convert an antiplatelet drug to its active form, resulting in higher risk of adverse outcomes after angioplasty. What is the danger of not having this vital information to inform our treatment decisions? Without Pacific Islander participation, we would not have known this risk for this population. In studies where this population is under-enrolled, we would have missed this outcome. The next table provides other insights from other studies that really should inform how diverse ethnic and racial groups experience a variety of different diseases and how we should really be attentive to and being inclusive in our study samples. Diversity really does matter. A lack of diversity in clinical trials is a moral, scientific, and medical issue. When trial participants are all within one group, findings may be skewed and the results may not be generalizable to the target populations. Why do we exclude specific populations? Well, that's a complex question with complex answers. It's influenced by potential subject issues, provider issues, funding issues, and investigator factors. Exclusions can be planned, unintentional, or they may simply reflect non-participation or a combination of these factors. The challenge is we need to overcome these factors. One of the critical and most often cited reasons that people don't participate in research is the fear of exploitation. And there's good reason for folks to have these fears. There are too many examples of abuse of research participants in the United States. There are many examples of unethical research studies in U.S. populations, such as African Americans in the Tuskegee study of untreated syphilis, the Havasupai tribe in Arizona. The study was designed to examine type 2 diabetes, the Willowbrook study of children with cognitive disabilities, and the Jewish Chronic Disease Hospital of Older Adults. And in this sample, these residents were injected with live cancer cells. And then there's the study of poor Mexican American women who were unsure whether they received contraceptions or not. In the case of the Havasupai tribe in Arizona, this is a really recent event in 1990. And ASU researchers drew more than 200 blood samples from this tribal members, and blood samples were removed from the study site without permission. The blood was shipped overseas without permission and used for non-IRB approved studies. This was a debacle. The challenge for the tribe members is that they believe that all biological human material must be intact for an individual's spirit to travel to the afterlife. Arizona State University earned the tribe's mistrust. They earned it. Such egregious actions lead to ongoing mistrust, which is difficult to overcome. What are the barriers to ethnic minority enrollment and participation in research trials? Well, 3.9% of physicians identify as Black and 5.3% identify as Hispanic. Most minority patients see minority providers. Fewer minority physicians are investigators. When asked by their providers, 75% of patients participate in research if they are asked by their provider. The math does not favor ethnic minority patients having equitable opportunities to know about enrollment in clinical studies. Where do we conduct clinical studies? Seldom are they in study sites, in poor neighborhoods, or community hospitals. Some providers are unaware of the availability of clinical trials in their areas. What can we do to address these issues? Research has shown that many ethnic minority patients are never even asked to participate in research studies, engendering mistrust. Language and cultural barriers may deter participation because research designs and research budgets do not address these critical issues. Other barriers. Trial designs that require repeated visits, travel, and days off work may be problematic for hourly wage earners, individuals with inflexible work schedules. Reimbursement for travel costs becomes problematic if participants don't have the funds to get to the site, even though reimbursement is promised and planned. Childcare may help prohibit participation in young families or in families where the grandparents or other family members are raising grandchildren. Some researchers may assume that certain groups won't participate when in reality they will if resources are available to support their participation and explanations are clear and meaningful. Some communities are unaware of clinical trials and what it means to participate in clinical trials. The research teams that I have had the pleasure of working with have enjoyed diverse representation in our studies. In our most recent study, we recruited more than 100 adolescents in Memphis with asthma to a 15-month study with retention rates exceeding 90%. Finally, I want to emphasize that ethnic minority participants will participate in research under certain conditions. In a meta-analysis conducted by Wendler and colleagues in 2006 of 20 health research studies involving more than 70,000 ethnic minority participants, they found that they were more willing than the majority participants to participate in research. Now, I understand that saying you will participate doesn't always translate into participation, but there's a willingness there, and we have to capitalize on that willingness. The greatest challenge for achieving diversity in studies is often the greatest challenges achieving diverse study sample often is with ethnic minority groups, as opposed to women, older adults, and other groups. And this is why I've spent so much time on this issue. So how do we achieve a sample that has diversity and inclusion that allows us to meet our diversity and inclusion goals? One of the most important approaches is the use of communities, engagement with communities to determine research questions and research designs. This kind of a model is considered community engaged research. We have also found that engaging with communities offers dividends in our studies here at UTHSC. Our investigators and other investigators have also documented well in the literature building sustained relationships with populations and communities of interest to get them engaged in the research process, to serve as champions for the research process and research studies. About 10 years ago, I had the pleasure of attending a community advisory board for a local organization. There were many of us there representing UTHSC. We were forever being asked, or we were forever asking this community advisory committee to help us with a variety of different studies that we had ongoing here at the university. But when we were asked to help with community projects, the response in the room was often dead silence. Some of us in the room helped these stakeholders make critical connections with university colleagues we knew would be interested in partnering with them. Sometimes we volunteered ourselves because we had the expertise to help. We cannot expect to develop sustainable relationship with community organizations if we're not willing to give something in return. This recommendation is not solely my position. The literature is replete with investigators and agencies like the FDA and the NIH supporting the importance of exchange between researchers and communities to improve health. Such an approach creates a win for both parties. Let's talk about some other specific kinds of strategies to use. And many of these do include community-based engagement approaches. Pilot test. Think about pilot testing recruitment approaches and exploratory and feasibility studies to support your diversity recruitment and enrollment plans for large-scale studies. Interview study participants after every study to gain insights that inform future studies with the population, and then share your findings so other people can learn from your insights. Identify critical community organizations whose members are members of the target population, and they can help to develop successful diversity recruitment and enrollment plans and inform solutions to enrollment barriers. I had a good colleague who recently died who was exceptional at this building community organization capacity with researchers in the Chicago area and really seeing a lot of benefit and a lot of minority participation in research trials. Consider creating opportunities for enhancing the culture of humility in all study team members. Invite diverse community residents and other stakeholders to town halls, sharing study opportunities and study results. Have former participants join these events as champions. You know, I've had the pleasure of having a session here on campus many years ago that was a panel discussion where one of the participants in one of the studies that I had the benefit of being the lead investigator on came to the panel and talked to community members about why she thought it was important to participate in research, particularly since her experiences with research as a family caregiver were so critical to her mental health. Consider enlisting diverse former study participants to serve as part-time paid and trained study champions to recruit for new studies. Consider technology and telehealth approaches to engage participants when possible, particularly when they have inflexible work schedules. Make diversity a mandate for every study that you conduct where it's appropriate. Engage with ethnic minority provider groups, informing them of your trial and potential benefits. Get on their board meeting agenda, sending them study newsletters as updates. Interact with healthcare personnel at potential recruitment sites during their slow periods. Work with community-wide initiatives that align with your research focus. Diabetes Awareness Month, health fairs, street fairs. The Shelby County School System several years ago when we had our asthma study had an Asthma Awareness Month event. And we had the opportunity to be on the school system's radio station to talk about our study. Create an advisory board of patients and family caregivers to inform the study questions, designs, interventions, and of course, the recruitment and inclusion plans. Work with large and small places of worship to recruit across socioeconomic status. Even small storefront churches often have health ministries, and these health ministers are open to improving the health of their congregants by participating in healthcare research. Develop IRB-approved newsletters that share stories about participants in the study to distribute during recruitment and enrollment events. Share end-of-study results to inform participants of findings and the importance of their contributions to the study, supporting the value of participating in future clinical trials. When people have good experiences in clinical trials, they speak highly of research in the community. Provide refreshments and supervised childcare activities, books, coloring books, board games, jewelry making during enrollment visits. Routinely monitor and evaluate the recruitment strategy success of your team. Add new IRB-approved approaches to achieve enrollment goals. This is a dynamic process and it requires work. Invite advisory board members to contribute as co-presenters and co-authors to maintain their interest and commitment to the study's diversity goals, but also so that they are out there championing research for communities. Recruit diverse team members as patients often feel comfortable when they see study team members who they identify with. This is called affinity bias. Have open, informed dialogues about recruitment challenges. It's nothing to be embarrassed about, it's something to be worked on. Consulting with colleagues who have been successful. In a recently completed multi-site trial, we enrolled 371 adolescents and their parents to a 15-month study for asthma self-management. You will note that nearly 80% of these teens were African American and 8% were Hispanic. The study retention rate was around 80 to 85% for all 3 sites. The 3 sites were in Baltimore, Rochester, New York, and of course, Memphis, Tennessee. And here in Memphis, we were fortunate to have a retention rate of 92% for our site. And we had the best evaluations too for our intervention component, which was a camp for teens with asthma. So we have experience recruiting minority patients. Most that we reached out to enrolled in these studies. In previous studies, we have had participants ask us, Dr. Wicks, when are you all going to have another study? A teenager in the asthma study said, Dr. Wicks, can I come to the intervention again? My mom will let me. African Americans, ethnic minorities will participate in research if it has meaning for them. No single approach is going to work. I've talked about a whole lot because there's so much diversity within and across ethnic minority groups and other populations. Do the work to know your population. Results requires intentionality and an investment in time and resources. And I understand that this also means money. The payoff is increasing success, defined as reaching targets and conducting research that can be generalized. Conducting post-trial interviews is useful for gaining understanding regarding what worked and why. Conducting research with populations is a balancing act. It requires balancing resource investment with a return on investment. The goal is to acquire the best information and treatments to influence the most people with the diseases and to do so effectively at the lowest cost possible. The challenge is that if we exclude or under-recruit the people who are disproportionately affected by the disease and who experience the most frequent and devastating effects, have we made the best use of scarce resources, especially when treatments are not efficacious because study populations lack important diversity and inclusion? Diversity and inclusion strategies help to address these challenging dilemmas. They help to address health disparities. Beyond diversity and inclusion is the importance of having representative samples. Representativeness means a sufficient number and type of people are included to ensure that those enrolled represent the target population for whom the treatment is intended. It refers to the who and the how many individuals to include as closely as possible to the target population so that the results of these studies represent or are generalizable to the broader patient population. The proportion of taxpayers in this country who have not gained optimal benefits from scientific discoveries they are funding through tax dollars continues to grow with the changing U.S. demographics. Therefore, ensuring that diverse populations are adequately included in scientific research is an imperative, not only in terms of scientific integrity and fiduciary responsibility, but also as a matter of social justice. Thank you. Now we will entertain your questions and I hope have some very thoughtful discussion.
Okay, Mona, I've got one for you.
Okay.
I have seen, sitting on the IRB committee, a research study which would cover the cost of those who were not insured. So no cost to participate, but participation for those with insurance would potentially place those persons at a disadvantage because they might have out-of-pocket expenses of thousands of dollars.
Right.
So is there a way to change that diversity profile? Would there be confounding issues that uninsured subjects might have more comorbidities due to lack of access to health care? And is this an example of exploitation for those without insurance? I know this is a loaded case study, but I just thought it was really, I've not really ever seen that before.
Mm-hmm. And so one of the things that I think we have to be cognizant of, Margaret, is that what we do to enroll patients requires that we really understand our samples and that we have, as a team, dialogues about what it means when we have differences in approaches to recruiting subjects. And do the differences create an undue burden for some and not for others? Because that becomes a problem, right? And so what I believe should happen is that I think we need to be a little bit more thoughtful about setting budgets and using resources or using resources that that are equitable. And what that means for the population, it requires ethical discussions. I think too often as researchers, we don't take advantage of the people that we have on our campus who are ethicists to help us kind of navigate this issue. And I think sometimes we just make decisions trying to get the numbers, so to speak, and trying to be sure that we do include diverse samples. But at the same time, I think we need to have more thoughtful discussions about what those different plans mean and the feelings that they might create amongst members on the study team. Because people have different perceptions about how people should be accommodated so that they can participate in a study. And I think these are the kinds of discussions that most study teams don't have, but they need to have. So I don't know if that really answers your question. That's a very difficult question to answer, but I just believe that these kinds of dilemmas require careful discussions, and sometimes the consultation with ethicists to help us navigate this issue, and even to talk with community stakeholders to help us navigate this issue. And a great conference would be if we would have a conference focused on some of these issues and having some dialogue as a community of scholars in the UT system about how to navigate these issues in the best way. So I know that was a very long and very not responsive answer, but I just don't know the answers to those questions, Margaret. But I think it requires thoughtful consideration, dialogue, planning, and coming to some consensus as a scientific community about how to address some of these issues.
So what do you think the results of that study will be, given the fact that it's really, I mean, of the comorbidities and things that uninsured population would have, those characteristics, are there going to be valid results from that, you do think?
Well, so the question is, what is the question that's being answered? The challenge is, whenever you do any kind of intervention trial, you want to create a situation where you have the least amount of confounders, right? The challenge is that our patients have those confounders. And so maybe in the early studies, it may be important to look at a treatment without the confounding, comorbid conditions that will influence the results. And then as the study grows, we have to include those people, because ultimately, if we don't include the people who have the comorbid conditions, then how do we know that the results of the study meet the needs of the people who have the comorbidities? One of the things that for example, I know Dr. Jim Bailey does is those pragmatic trials where you really have to just kind of include people, because that's who you're trying to treat with these drugs and medical devices and behavioral interventions. You're trying to treat real people with real problems, and real people with real problems don't look like the sterile people that we include oftentimes in clinical trials. So it's a balancing act. In some stages, we may have to begin a certain way, but we have to consider that if we want these treatments to be meaningful to folks who have comorbid conditions, ultimately they're going to have to be included. And we have to include sufficiently large numbers of folks so we can control for some of those things when we do statistical analyses and that kind of thing with our good colleagues like folks like Betsy Talley.
Yeah. Do you have some suggestions specifically for what to add in your budget when you are trying to recruit for a diverse population? You put some of those on your slides, but anything in particular?
Well, so I think it has to be tailored to the approaches that you're going to use for the population. You have to identify from your population what would get them in the door, so to speak. And so sometimes you have to do that preliminary work. Remember, I talked about the importance of doing feasibility studies. You know, oftentimes when we do pilot and feasibility work, we're testing, doing small tests of the intervention, testing instruments. We need to do, and we even will test recruitment strategies, but seldom do we test the diversity aspects of our recruitment strategies. So I think you have to build in things like, in your small test of feasibility for your study, you have to build in diversity recruitment and develop a plan that you think will work because you've been given advice by stakeholders, patients, people who've worked with the population in previous studies, your own insights that you gain from working with those folks. And it's going to vary. Some people, like, for example, I'll tell you about my experience with these families with asthma, the teens with asthma. So we originally, we included things like gift cards periodically. They came to a camp, and we had to have food there because the kids were going to get hungry. And then we recognized that if we were not careful at the 15-month point, we might not get the results that we need, the number of returns that we need. And we have been in contact. We have been sending birthday cards. We've been selling holiday cards. One of the things that we did was after every collection of data, we looked at the data to see what kinds of events were going on in these families, those kinds of things. So you add things in to not only recruit them, but also to retain them, because that's another part of the diversity issue, is being able to retain them in the study. And what we do, what we really did, and it really was very effective, is that if someone had a death in the family, for example, one of the parents had a death in the family, we sent a handwritten sympathy card. If someone had a hospitalization, we sent a handwritten note saying, "We're glad you're better." So it's an investment of time and money, and there's no one answer, Margaret. You have to know your population. You have to make adjustments. You sometimes have to go back to the IRB, and sometimes you have to, if you haven't budgeted adequately, is look for outside sources like small grants from foundations and things like that to supplement when you realize that you've under budgeted for the things that are needed to be successful. And the more you do these kinds of things, you'll start to learn what works and what to include in terms of cost. That's a long answer, but I think there's no simple answer to many of these questions.
No, those were good examples. The last question that I have is, can you comment on phase 1 trials that are done in third world populations? I've always struggled with that as a ethical potential exploitation.
And so I have no experience with that personally. I get concerned about research being conducted in places that are under-resourced. It requires that the investigative team really attend to the needs of the participants and not provide a resource that could potentially reflect an undue inducement. And I think one of the strategies to try to get around that is investigators who conduct research in underserved or under-resourced countries would work with, again, the community to identify what would bring the people in at a level that meets the recruitment goals so that you can answer the critical questions without it being an inducement that is they feel like they have no choice but to participate in the study. So I think, again, working with the people will give you many of the answers. And, I think sometimes we overlook the fact that people who have disease have an expertise. People who live with disease every day have an expertise. And I think we overlook that often.
Great answer. Tarita, I'm going to turn it over to you.
Thank you, Dr. Wicks. As always, it's a pleasure to hear you speak and share your wealth of knowledge with us. And I know each of us can utilize this information you presented today to understand the importance of diversity and inclusion, and also to assist us in knowing the value for us to reevaluate or evaluate our practices in order to enhance the inclusion and diversity of our participants when we're conducting research. You've given us a lot of food for thought and a lot of good examples of what we can do to increase the diversity and inclusion participants in our study, and we thank you for that. It was a great presentation, as always, and I'm sure most of us learned a lot of stuff. So Margaret and I invite everyone to join us for our next and final Research 103 session, which will be next Tuesday, the 27th at 11:30. Dr. Mark Miller will be, who is our UTHSC's Research Integrity Officer, will be presenting scientific integrity and preventing research misconduct. And again, thank you, Dr. Wicks. We appreciate you giving us all that great information today. And Margaret and I thank you for attending today's session and wish everyone a great rest of your day.